Yeah, I can see your slides.
Yeah, we can see, sir. We can see.
Yeah. Okay. So we start?
Bashirji, please start.
Okay. So good evening, everyone. I'm Dr. Vinod Ravindran. I'm the Secretary of Indian Rheumatology Association, and also with my team, we've been putting this IRA eConnect together. Today is the second edition of the IRA eConnect, and as speaker, I'm delighted to welcome Professor Ernest Choi from the United Kingdom. And I would like to start the meeting by requesting the President of the Indian Rheumatology Association, Dr. Chandrasekhara, to start with his welcome address. Dr. Chandrasekhara.
Thank you, Ravindran. Good evening, everyone. I think in our continued effort to keep ourselves updated and keep ourselves connected, I think this particular program, which we started as a part and parcel of a connect during COVID time, I think we thought since it's working nice and it's one of the easiest and the simplest way to get connected, we even continued post-COVID era too. I think this is one of our second edition. I think last time we had a very good enthusiastic response, and I hope even this time many will join. And we'll invite all of you to join this session. And I invite Professor Ernest to having agreed to deliver this lecture. Of course, I do agree on a working day at 3 p.m. In your place. It's we are really happy to have you with us to present this brief discussion on cardiovascular disease. And I welcome you, sir. And I welcome all the delegates and everyone. Over to you, Dr.
Yeah, thank you, Dr. Chandrasekhara. I would Dr. Damodaran, who's the moderator for this session, to start the proceedings. Dr. Damodaran, as you all know, is our very hardworking, gentle, but tight-fisted treasurer of the IRA. So over to you, Dr. Damodaran.
Thank you, Vinod sir. We welcome you all for this IRA eConnect Meet 24-25. And we have to chair this session, we have our senior most rheumatology faculty, Professor Mahendranath sir. And you know very well about Professor Mahendranath sir. And we also have the esteemed speaker, Professor Ernest Choi. And any questions, you please put in the chat box. And after the session, we'll discuss all your questions by the honorable speaker. And now I like to invite Professor Mahendra sir to introduce our guest speaker, Ernest Choi. Over to Mahendra sir.
Thank you, Damodar. Am I audible?
Yes, sir. Yes, sir. Yes, sir. Audible, sir.
Yeah. Thank you, Damodar, Chandrasekhar, and Vinod Ravindran. It's a pleasure to chair this meeting. I think I probably met Ernest Chai about, I don't know whether he remembers or not, about 30 years back in one of the BSR meeting. When I started my rheumatology training in 1978, I think it was still not very much known. And when I came back to this country and started going as a visiting rheumatologist, I think Ernest had started his career in Northern England at that time. Then he later moved to King's College, and then he moved to Wales. And during these 3 decades, I think every meeting I see him in BSR regularly, either giving a talk or ULR and other places. And last Liverpool meeting, I just briefly bumped him across outside the venue. And Chai is Ernest Chai right now is in Cardiff University. He is a professor of rheumatology, immunology, division of infection and immunity. and he's also the director of CREATE. And he has done tremendous work in the field of rheumatology, particularly cardiovascular risk factors. He's a great teacher and he's a compassionate clinician. What I've heard from occasional patients whom I've come across during my locum periods in England in 90s and early 20s. And he's a brilliant speaker. He's a very hard worker. I don't think there are many people in the international rheumatology field who has done so much of work, rheumatoid arthritis and cardiovascular risk factors. And it is a pleasure to have Ernest today to talk to us. Ernest, you're welcome. It's your field.
Thank you very much for those very, very kind words. And I appreciate the opportunity of sharing one of the research topic that has been close to my heart for several decades now. Also, these are my disclosures. So it is well known that rheumatoid arthritis patients have increased mortality compared with the normal population. And this is a review by Shireen Gabriel from the Mayo Clinic, published in 2008 in Annals of Rheumatic Diseases. The main cause of death is cardiovascular disease, as she highlighted in this review. And many studies have studied cardiovascular disease in rheumatoid arthritis, and they all come to the same conclusion. That is, in patients with rheumatoid arthritis, there is an increased risk of cardiovascular event. And a meta-analysis of all this study concluded that patients with rheumatoid arthritis have a 50% increased risk of cardiovascular event compared with the normal population. Now, the one thing that is novel about this cardiovascular event is that, in fact, they are very different from cardiovascular event in the normal population. So this slide is looking at coronary artery disease in patients with rheumatoid arthritis and as well as ankylosing spondylitis. And they compare that between patients with cardiovascular disease and those who did not. And surprisingly, what they found was that, in fact, in patients with cardiovascular disease, their cardiovascular disease is asymptomatic. So in fact, the majority of the patients never complain of chest pain. The event happened is a cardiovascular event, either a stroke or myocardial infarction, but the patient don't present with angina. And this is one of the underlying reasons why in the EULAR recommendations for screening for cardiovascular disease, it mandated that this is the responsibility of rheumatologists, because there's no chance that the patient, based on the symptom, will be presenting to cardiologists to get a consultation. Now, cardiovascular risk factors are well researched and publicized in the normal population. These are listed on this slide. These include age, cholesterol levels, smoking, diabetes, hypertension, family history, BMI, physical activity, alcohol. Interestingly, in rheumatoid arthritis, if you adjusted for these known traditional cardiovascular risk factor, it really doesn't account for most of the increase in cardiovascular risk. So in this study published in Arthritis and Rheumatology, it shows that after adjusting for the traditional cardiovascular risk factor, it only accounts for a small proportion of the cardiovascular risk. So if you do an age and gender adjusted comparison, the risk of patients with rheumatoid arthritis having a cardiovascular event in this study was close to 4 times. But if you adjust it for the cardiovascular known risk factors, then there is still a 3 times increase in risk that cannot be explained. So something that is related to the disease itself is causing the cardiovascular event in rheumatoid. Many studies have found that inflammation was an independent risk factor. In this particular study, categorizing patients into high, moderate, low disease activity and those in remission, you can see that patients with the highest disease activity have the highest risk. Patients with in remission have the lowest possible risk. So these kind of result led to EULAR recommending that cardiovascular disease needs to be screened in patients with rheumatoid arthritis, and it highlighted that the traditional cardiovascular risk score would underestimate cardiovascular risk in rheumatoid, and recommended that the traditional cardiovascular risk score should be increased by 1.5 to adjust for the unknown cardiovascular risk factor, which is the modified EULAR score. In the next remaining part of my talk, I will explain why the traditional cardiovascular risk score failed to predict cardiovascular event in rheumatoid. And in fact, also explain to you mechanistically why cardiovascular disease in rheumatoid arthritis is not a concomitant disease. The disease is actually caused by the inflammation generated in the joint. So first of all, the first part of my talk is to explain to you the inverse relationship between inflammation and lipid measurement. So as you all know, lipid measurement is a key part of cardiovascular disease screening for the normal population. But in fact, what we know is that inflammation affects lipid level. Lipid is a negative acute phase reactant compared with CRP, which is a positive acute phase reactant. So a positive acute phase reactants are proteins that are increased during inflammation. So CRP is one, fibrinogen is another. But negative acute phase reactants, such as lipid, are those proteins that are suppressed during inflammation. And when you remove inflammation, the level starts to become increased again. So what is the reason for this? Well, the conclusive evidence of this event was shown by Shireen Gabriel at the Mayo Clinic. And in fact, she used the term the lipid paradox in rheumatoid arthritis, because in this study, she showed that if you look at patients with rheumatoid arthritis and look at the hazard ratio for cardiovascular disease, adjusting it by the ESR, you can see that instead of high LDL level being associated with cardiovascular disease in the normal population, in patients with rheumatoid arthritis, it is the patient with low disease activity that have the high risk of cardiovascular events. So this is the absolute opposite to the normal population. The second reason why lipid was unable to predict cardiovascular event in patients with rheumatoid is that, in fact, inflammation affects the function of the lipoproteins in the body. So you will know that LDL, which I've just shown you, is known to be a bad cardiovascular risk factor because the role of LDL is to take cholesterol from the liver into the circulation. HDL is known to be a good lipoprotein. It is because the function of HDL is to carry cholesterol from the circulation back into the liver. So they have the reverse role, if you like, in lipid metabolism. Now, when you look at the composition of HDL in patients with rheumatoid arthritis, such as this study has done, what they found was that, in fact, the size of HDL in patients with rheumatoid arthritis is substantially higher than the normal population. And what they found was that the HDL were carrying lots of proteins on the surface. And if you look down the list, and I've listed the most common proteins that these HDL are carrying, you will realize that some of these proteins are part of the acute phase reaction from the liver. So these include fibrinogen, complements, D1, serum amyloid A protein, haptoglobulin, and ApoJ protein. All these proteins tend to be proteins that are released during inflammation. So what it seems that this HDL are doing in patients with rheumatoid arthritis is that because these patients have active inflammation, these proteins are being released into the circulation. The HDL are binding to these proteins. But what this then affects the HDL is that because it's binding to all these proteins, its ability to carry cholesterol is reduced. And this is reflected in this slide. So this slide look at the percentage of cholesterol being carried by HDL, and they compare the amount of cholesterol carried by the HDL in patients with rheumatoid arthritis who are in remission, which is in the black bar, compared with patients with active inflammation with a DAS score of more than 5.1 in the hatch bar. And you can see that the amount of amount of cholesterol carried by HDL being carried by patients with active inflammation is substantially reduced. So you can have the same amount of HDL by circulation, but the ability to HDL to perform as a protective lipoprotein is affected by the presence of inflammation because it's bigger, it's carrying other proteins, and it cannot carry cholesterol as a result. So that shows why our current cardiovascular risk score fails to reflect cardiovascular event in patients with rheumatoid arthritis. That's because of the confounding influence of inflammation. In the next part of my talk, I will explain how inflammation directly causes cardiovascular disease in patients with rheumatoid arthritis. Now, in the world of cardiology, it is now become increasingly apparent that coronary artery disease or ischemic heart disease is not just a disease of lipid abnormality in the blood vessel wall. It's not just about blocking of the coronary artery with cholesterol plant, which is driven by lipid metabolism. It is considered to be a chronic low-grade inflammatory disease of the blood vessel wall. And this is a seminal work by Paul Rickard from the Mayo, from Harvard, when he first shows that if you take normal, healthy individuals, and in this study, first of all, in women, if you measure high-sensitive CRP in these women, then you will find an extremely nice linear relationship between the level of HS-CRP and future cardiovascular event in these asymptomatic, healthy women. In fact, he repeated this study in apparently healthy men, and in fact, he replaced CRP with interleukin-6 level and actually find exactly the same type of dose response between the level of IL-6 and the relative risk of myocardial infarction in the future. Since then, a number of genetic studies using Mendelian randomization analysis published in the Lancet confirm and suggested that SNP associated with interleukin-6 receptor is associated with cardiovascular risk. So the purpose of doing a Mendelian randomization analysis is that this methodology is considered the method in which you can infer causation in pathogenesis. So what this study is suggesting is that interleukin-6 receptor is biologically important in causing cardiovascular disease in the normal population. Now, if you think about the normal population compared with our patient with rheumatoid arthritis, what we will recognize straight away is that when we look at the level of inflammation in the normal population, even in patients with coronary artery disease, the level of inflammation is really very low. The reason why they have to use high-sensitive CRP is that these individuals in the normal population, the level of CRP is usually below the detectable limit of just a standard CRP assay. So you have to have a high-sensitive CRP assay in order to measure the increase in CRP in the normal population. If you compare this with our patient with rheumatoid arthritis, the inflammatory burden is so high, ESR and CRP are elevated. We don't need to have a special CRP assay in order to measure the level of inflammation in our patients. So inflammation is much more prominent in patients with rheumatoid arthritis compared with the normal population. And in fact, one thing we know that about cardiovascular disease in patients with rheumatoid arthritis is that it occurs extremely early. It's not a consequence of long-term disease. If you look at patients with early onset of rheumatoid arthritis, you can see that particularly in the rheumatoid factor positive individual, especially in female, increase in cardiovascular event occurs very early on, soon after the diagnosis. This is a study that we did in Cardiff, performed by my research fellow, Ruth Davis, in our early arthritis clinic. And she assessed cardiovascular risk score in patients who just have the diagnosis of rheumatoid arthritis. And in addition to performing the cardiovascular risk score, and in the UK, we use the Q-RIS2 score, she also performed carotid ultrasound to measure the intimal media thickness as a surrogate marker of the presence of atherosclerosis. What she found was that even at the time of diagnosis, many patients with rheumatoid arthritis would have been deemed having a sufficiently increase in cardiovascular risk that would justify starting these patients on a statin therapy. So 53% of the patients have a cardiovascular risk of greater than 10%, according to the Q-RIS2 score. And these patients already have increased in the carotid intimal media thickness at the time of diagnosis. So Eva Masudova from Mayo Clinic then showed that in patients with established rheumatoid arthritis, every time they have a disease flare, they double their risk of having a future cardiovascular event. So what this indicates is that inflammation and flare and the disease itself seem to be strongly associated with cardiovascular event in patients with rheumatoid. In the opposite end of the spectrum of evidence, there are strong evidence that suppressing inflammation can reduce cardiovascular mortality. So these are data related to methotrexate, and you can see that methotrexate can reduce cardiovascular mortality in patients with rheumatoid arthritis by something like 70%. And in fact, there are similar evidence for TNF inhibitors. TNF inhibitors seems to reduce cardiovascular mortality compared with patients just treated with conventional synthetic disease-modifying drugs. Interestingly, in studies of lipid metabolism with TNF inhibitors, many studies have shown that TNF inhibitors also cause increase in lipid level. So again, a paradox relationship. So TNF inhibitor reduce cardiovascular event, but paradoxically, it increases lipid, which support what I told you earlier. In fact, inflammation is a mirror image of lipid metabolism in patients with rheumatoid. So for the last part of my talk, I'm going to show you some work that we have done in my department to look at the potential role of interleukin-6 in causing cardiovascular disease in rheumatoid. In a study that has been published a couple of years ago in Rheumatology Oxford, we use collagen-induced arthritis as a model of rheumatoid arthritis. In this study, we can show that in mice that has developed inflammatory arthritis, not only they have an arthritis, which is shown on the left-hand panel of this slide. So the PBS control mice is shown in blue. The non-immune mice is shown in black. So you can see that when you immunize the mice with Floyd's incomplete adjuvant, they develop an arthritis. If you look at the aorta of these mice and look at its ability to contract and relax, what you find in the mice who develop an inflammatory arthritis is that the aorta has become stiffer. They're less able to relax compared with normal animals. And if you give them a treatment that blocks interleukin-6 transsignaling, and in this experiment, we use an agent called soluble GP130FC, it was able not only to reduce the arthritis shown in red on the left-hand side, it also restored the aortic contraction abnormality of the aorta. Now, in this mice, what we find was that there's an inflammatory marker that is associated with arthritis called VCAM1. The level of this is increased, and it has a low level of correlation with the arthritis. If you look at VCAM1 level and the contractility of the aorta, in fact, you also find that the VCAM1 level was related to the level of contractility or cardiovascular risk in these animals. And when she go back to her early arthritis study and look at patients with rheumatoid arthritis, what she found was that VCAM1 level correlated with disease activity, such as the DAS28 score on the bottom right panel. It related to IL-6 level, shown in the top right-hand panel of this slide. And importantly, VCAM1 level was higher in patients with higher cardiovascular risk score. So I think what this experiment is showing is that it seems that IL-6 transsignaling is associated with aortic or cardiovascular pathology in individuals with inflammatory arthritis. And one of the markers of this inflammatory activity is the level of VCAM1 in the circulation. She then do an opposite experiment and asked the question whether IL-6 can cause acceleration of atherosclerosis. So in this experiment, she take animals that are prone to develop atherosclerotic disease, a type of animal called ApoE deficient animals. And these animals, when they feed them with a high-fat diet, would develop an atherosclerotic plaque, which is shown on panel A of this slide. And you can see a small plaque at the bottom right-hand corner of this slide. She injected this animal with recombinant interleukin-6, and in panel B, you can see how big the plaque has now increased as a result of injection of interleukin-6. And in order to mimic the condition we see in patients with rheumatoid arthritis, which is there's an increase in the presence of IL-6 as well as soluble IL-6 receptor. When she injected a combination of IL-6 and soluble IL-6 receptor to these animals, in fact, it further accelerated the plaque formation in the slide in panel C and D. And in fact, this graphically showed the level of acceleration of atherosclerosis in this animal. So the control mice is in the first column. Injection of IL-6 increased this slightly, but injecting the combination of IL-6 together with soluble IL-6 receptor further increased the risk, even when compared with injecting IL-6 alone. And in fact, in these animals, we also find there is an increase in VCAM1 level, as we have shown previously. So what we have found in this study is that the cardiovascular disease is not just a concomitant disease in rheumatoid arthritis. Indeed, there is an interaction between traditional cardiovascular risk factor and inflammation in patients with rheumatoid arthritis. On the one hand, inflammation affects our ability to quantify and qualitatively assess lipid changes, so they become less useful as a cardiovascular biomarker. On the other hand, systemic inflammation can interact with traditional cardiovascular risk factor to accelerate atherosclerosis. So patients get accelerated cardiovascular disease, and this would explain why symptomatically this is so different and why patient may not be symptomatic because of the rate of development of that cardiovascular disease. So in summary, I've tried to explain to you cardiovascular disease is increasing rheumatoid arthritis, and in fact, traditional cardiovascular risk factor, including lipids, cannot account for the increase in cardiovascular risk. Inflammation, as measured by ESR, are significantly associated with increasing cardiovascular risk, and inflammation and lipid level have an inverse relationship. Controlling inflammation reduces cardiovascular risk in rheumatoid arthritis, and we have evidence that interleukin-6 is a major driver of the systemic inflammation, including the acute phase response. And in fact, we have produced evidence that IL-6 signaling can directly accelerate atherosclerosis in experimental models of rheumatoid arthritis. Thank you very much for your attention.
Thank you, Ernest, for brilliant and informative, delightful talk. Like across the world, we are also in India saying nowadays, we are treating rheumatoids very early. We don't see much deformities, patients wheeling into the outpatient department similar to UK. It's not happening here, but we are seeing patients dying very young and early. Probably cardiovascular risk factors are causing the damage, which probably we have started noticing it in the last decade much more. I just wanted to one observation about you. You look more younger and fitter day by day whenever I see you. Accent yet. And I just wanted to, can I ask one question, Vinod?
Yes, sir.
Is there any difference, Ernest, in the cardiovascular risk mortality in your studies among, are there any papers or documentation, vegetarians and non-vegetarians?
Yeah, we don't have that data about diet in patients with rheumatoid arthritis. I don't think there are many good papers looking at the influence of diet in rheumatoid arthritis. Diet obviously has an impact not only on cardiovascular disease, but also on the level of inflammation. A very strict diet can reduce inflammation. It's true. There's some evidence of very, very strict diet can reduce inflammation in rheumatoid, but those diets are so stringent, it is not standardly recommended by many societies.
Thank you.
Thank you, Ernest, for your excellent talk. And we have a few important questions. And the first question by Professor A.N. Malavia. So he asked, what is your take-home message from LODOCO-2 trial, that is low-dose colchicine in preventing cardiovascular events? And how can we attribute it to in the rheumatology practice? So the first question. Another question by Professor A.N. Malavia is, what is the take-home message for this use of low-dose corticosteroids in preventing the atherosclerosis? And also in asthmatic patients, it was proven that those who use inhaled corticosteroids, the intimal carotid media thickness is significantly lower than who don't use inhaled corticosteroids. So, so what is your take-home message and what is your advice regarding low-dose colchicine and low-dose corticosteroids?
So let's take the corticosteroid first. For corticosteroid, there is the balance between inflammation, which is the benefit of steroid, and the long-term lipid changing effect. I would say that the challenge of using corticosteroid is getting this correct. So if you have a patient with active inflammation that you cannot control, when you give corticosteroid, by dampening the inflammation, you would derive some benefit from reducing inflammation. The challenge is that you need to balance and not over-treat in order to reduce cardiovascular event. If you just leave the patient on the same dose and you don't assess inflammation as frequently and the lipid changes as frequently, what often happens is the patient may be left with inappropriately high dose. So that's when you get into cardiovascular risk. And I think the position of EULAR and ACR over the last 5 or 6 years in all the recommendation, it's not just for rheumatoid arthritis, but true for vasculitis, for everything, is to taper off steroid very quickly. The reason being that if we have effective treatment, it's probably better to use other treatment than to use steroid. And I think the other thing that goes along with that is we need to screen the patient for cardiovascular event very early and effectively. So rather than not, I mean, the worst scenario is that you don't assess the cardiovascular risk. You put the patient on steroid, assuming that the steroid will protect the cardiovascular event, and you don't monitor it and change either the dose or cardiovascular risk in the future. That static approach is, I think, the harmful approach for using steroid.
We have a few more questions in the chat box. Do you recommend such patients should be given prophylactic aspirin to prevent cardiovascular events?
Yeah. So I would say yes. In the patient, particularly in early arthritis patient. So the standard practice for us to do would be to screen the patient for cardiovascular risk right at the time of diagnosis. If they have increasing cardiovascular risk, that would be the rationale to give them low dose aspirin together with lipid lowering drug. We would treat them with DMARDs to get inflammation down to remission, at which point we will check the cardiovascular risk again. And if the cardiovascular risk is increased, then, again, treat them with aspirin and lipid lowering agents, because that remove the confounding factor of inflammation on the lipid. So that's my approach. I forgot to mention that for colchicine, I mean, in gout, colchicine has been shown to have cardiovascular preventative benefit. The challenge of colchicine is that using it long-term is problematic because of the GI side effects.
And if a patient has got a persistent CRP elevation, even in the absence of CV risk factors, can we start aspirin in this group of rheumatoid arthritis patients?
So I think if you have a patient with persistent elevated CRP, although you can't see any inflammation, I will do several things. One is I will look for inflammation and any occult inflammation that I have missed. It may be in the lung, it may be somewhere else, because the presence of those inflammation would be a cardiovascular risk factor, and it's really important to remove the source of that inflammation. The other thing that is now commonly a cause, a reason for increased CRP is being overweight and being obese. And so losing weight, definitely there's strong evidence that losing weight can reduce CRP levels.
And when you recommend using statins in RA patients?
Yeah, as I said, so in the paper that I show you about this early arthritis clinic, all those 53% of patients were giving statin. And in the UK, it works very well because once you have done the initial screening and said to the GP that this patient will fulfill the nice criteria of starting a statin, they get started and then they get monitored annually by the GP.
And there is one more question in the chat box about the diastolic dysfunction in rheumatoid arthritis.
Okay. So all the things that I've explained to you in the main focus really on atherosclerosis. There's also evidence in part related to arterial stiffness that can affect cardiovascular function. That cardiovascular function in terms of heart failure and so on and so forth has been shown more to related to hypertension itself and stiffness of the blood vessel wall. And there's also some evidence that non-steroidal anti-inflammatory drugs can affect cardiovascular function. So it's a little bit more complicated than what I've explained to you, which is mainly focused on atherosclerosis. It's a slightly separate cardiovascular issue.
And there's one more question. The concept of lipid paradox is now less seen in newer editions of books. Has it been revamped in light of some newer updated research?
Sorry, I'm just
Is the
trying
lipid paradox is still valid in?
Oh, it's still valid.
And then, how do you measure CV risk, cardiovascular risk in your RA patients?
Okay, so I think it needs to be country specific. mainly because the prescription of lipid-lowering drug is country-specific. So in the UK, we use the Q-risk score. So when we did our research, the Q-risk score we use is Q-risk 2. Nowadays, the UK use Q-risk 3. And in Q-risk 3, we don't need to do the EULAR adjustment because there's an option. They ask you whether the patient has rheumatoid arthritis or not. If you tick that box, it automatically do the adjustment in increasing cardiovascular risk within that score.
And then how often you check serum lipids in arthritis patients?
So I do it usually at the time of diagnosis. And for conventional synthetic DMARDs, 6 months after the initiation of treatment. For biologic agents, I do it at the beginning of treatment and at 3 months, mainly because they work faster. So we're able to, by 3 months, most of the inflammation will have gone. So that will be the time I would expect the lipid to have been increased.
And then Dr. Dharmanand, our past president, so he asking, should we consider using statin and aspirin in poorly controlled rheumatoid arthritis?
I would say yes, but I would say that if you have a poorly controlled rheumatoid arthritis, the first priority is to suppress the inflammation. You need to change the medication.
Because in most of our Indian patients, they may not afford biologics. So in such cases, can we consider giving aspirin and statins?
Yeah, I mean, so what I mean is, even though they're on biologic, if they have very active RA, you definitely want to consider switching the patient. Giving aspirin and statin can be additional to that, but it doesn't remove the need to adjust the treatment to reduce the inflammation, because the inflammation will still drive cardiovascular event.
And there's one more question from Yogesh. So, which you give more weightage, interleukin-6 blockade using sarilumab, oleclumab, tocilizumab versus anti-TNF agents?
Well, we have one study called ENTRACT study that was a direct comparison between tocilizumab and TNF inhibitors. Cardiovascular events are the same in both groups. So both those biologic classes are effective in reducing cardiovascular event in rheumatoid. We don't know about the other classes as well. So we don't know whether the T-cell co-stimulatory blockers, rituximab, or the JAK inhibitors, whether they would do it to the same magnitude. I think obviously there's a question mark over JAK inhibitors anyway, but we don't have the same level of evidence with rituximab or with abatacept.
And one more interesting question from Arun Kumar, Kedia. So how do you stratify CV risk in young people? Because most of our arthritis patients are younger, especially middle-aged females. So in this group, how we can stratify CV risk, cardiovascular risk?
So that's a really good question, because the cardiovascular risk score really doesn't work in individuals under the age of 35. So there is a big gap in this area. I think in patients with lupus, with juvenile inflammatory arthritis, the challenge is that we don't really have a very good cardiovascular risk assessment for these individuals. So that is the current state of affairs. Once the patient is over the age of 35, the risk score started to work. So you can apply them in those individuals, but not in the very young.
Thank you, sir. And there is one last question. Is there any clinical markers? Do you regularly screen in RA patients for assessing the CV risk?
We are a bit lucky in the sense that we have Ruth who can do carotid ultrasound to measure intermediate thickness, but you need to be trained to perform that. So I think there are other groups who are looking at other imaging, cardiac MR. So some studies have shown that there may be increased calcium deposit in the coronary artery that may be used as evidence that PET-CT can highlight plaque inflammation in patients with IRA, but they're still being used as a research tool. They're quite expensive. Carotid ultrasound is probably the cheapest. And for those individuals who do musculoskeletal ultrasound, you can use the same machine and probe in IRA to do carotid intimal media thickness. But you need your cardiologist to train you how to do it.
Thank you, sir. And any questions from our president, Chandrasekhar sir?
I mean, it's a really interesting talk. Now, I have one issues. See, we had made one study where we tried to see the impact of inflammation in lupus-based disease and rheumatoid-based disease and spondyloarthropathic type of pathogenic processes. The impact on the overall lipid metabolisms seemingly were very different between these groups. I mean, lupus had a different impact where LDL used to go high and HDL used to vary, and the impact of the same on rheumatoid was distinctly different. What's your take on that, and how does it make it different in staging the cardiovascular risk with each of these patients?
So first, thank you for that question. So first of all, the mechanism where cardiovascular disease is increasing, these different rheumatic diseases are different. So we did a study where we look at cardiovascular risk and in fact cardiovascular event over 20 years in patients with rheumatoid arthritis and psoriatic arthritis. What we found was that in patients with psoriatic arthritis, whilst they have an increased cardiovascular event, the traditional cardiovascular risk factor contribute a lot more to the increase in risk. There is still some independent increase in risk, but that is only about 20%, much lower than in rheumatoid. In psoriatic arthritis, it's clear that the metabolic syndrome is far more common. It's more common than rheumatoid. And so that metabolic syndrome contributed a lot more to the cardiovascular event. So by inference, I would say that in the different chronic rheumatic diseases, the mechanism where they cause cardiovascular disease are different. So it's not a good idea to just take rheumatoid arthritis and say that this is all going to apply in other immune-mediated diseases. We need to study each of them in detail to come up with the right answer on how to reduce cardiovascular disease.
Exactly. I mean that's what the message I would like to drive through.
Yeah.
I have one question. Like in the patients who has got already existing coronary artery disease, so where he has already underwent angiography stenting or CABG. So in such group of patients, for tight control of the inflammation, so can we use which biologics? Can we use tofacitinib in the refractory cases?
Okay. The short answer is absolutely yes, because of what I explained to you. The inflammation is going to massively increase the risk. So putting them into disease remission is even more important than people without existing coronary artery disease. So the kind of biologic classes I would recommend is TNF and IL-6 inhibitor first, because we know the cardiovascular benefits from those studies. I would try, if possible, to use methotrexate and hydroxychloroquine in combination with those agents, not only because of the benefit on the disease activity, but because of the additional potential benefit on the cardiovascular disease. There's evidence that methotrexate and hydroxychloroquine improve endothelial function. And then if they have not responded well to those therapy, I go to either abatacept or rituximab. And if they have failed all those classes, then we will have to use a JAK inhibitor. We can explain to the patient with the risk, but uncontrolled inflammation would accelerate the cardiovascular disease risk. So, if you explain that very clearly to the individuals, that should be fine.
There is one more question by Shri Soni. Because both atherosclerosis and rheumatoid arthritis are inflammatory, so which comes first, arthritis or the atherosclerosis?
I would say in general is the cardiovascular disease that comes first. The reason for that is that there are many studies that involve looking at pre-IRA. So we know that the immune abnormality in rheumatoid arthritis occur many years before because they have ACPA antibodies. And in fact, in, I think, Switch's blood bank study, they show that these patients have abnormal lipids and already have high CRP level, way 10 years before they have rheumatoid arthritis. So I think the fact that we are finding increased carotid intimal thickness at the time of diagnosis in 53% of the patients will say that they have cardiovascular disease first.
Thank you, sir. Thank you. Very informative. And then this is one of the last question from the chat box. When using tofacitinib, should we add aspirin?
I don't know that you have to start aspirin, but I would definitely assess the cardiovascular risk factor at the beginning very carefully and shortly after you establish the patient on treatment. If you can show that the cardiovascular risk is increased, that will be the rationale of giving them aspirin.
Thank you, sir. And one more last question, sir. What about the homocysteine increased levels in RA patients, especially those who use methotrexate? So whether that can add a severe risk for this group of patients?
Well, it has been assessed before. It's just that the sensitivity and its ability to predict cardiovascular event in future is not as good as in the normal population.
Thank you, sir. So now we'll have, thank you, sir, for your excellent and informative session. And now we'll hand over the session to Professor Vinod for his concluding remarks.
Thank you, Ernest. It was a brilliant talk, and the interaction questions from the members were really great, very, very informative. So at the end, I would like to thank you for your excellent talk and giving us valuable time to discuss this important clinical entity in rheumatology. And thank you, Dr. Mahendranath, for chairing this session. Dr. Chandrasekhar, our president, for your presence, and Damodaram for an excellent moderating of this session. So I would like to thank everyone and the support team from ICS Global for making this event a success. Thank you, everyone. Thank you. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you, Ernest. Bye-bye. I'll catch up with you. Yeah. Thank you. Bye-bye.
Bye.
Bye. Yeah. Thank you.